Good evening. Welcome to DocTalks. I'm Patricia Hoffer, Vice President of External Relations here at St. Joseph's, and it's my pleasure to join you this evening. We have an interesting presentation for you entitled The Silent Thief, How to Protect Your Eyes, with Dr. Sydney Hutnik, ophthalmologist in chief and the leader of St. Joseph's Ivey Eye Institute. Eyesight, I think, is one of those things that it's easy to take for granted. And as I was getting ready for joining you this evening, I was recalling that my first encounter with the Ivey Eye Institute was over 30 years ago, and I was actually living in Northern Ontario. And I was referred to a physician here at the Ivey Eye Institute. Happened to have family that lived in London, so it sort of made it an easy ability to come and have a dual purpose. But I was really, at that point, very impressed with the care and the fact that I could access a program so far beyond our city limits. And that is so indicative not just of the Ivey Eye Institute, but so many of the programs here at St. Joseph's, which have that regional reach and which really set us apart. So wanted to share that little anecdote. I had to dig deep for that memory, but it did come back. So for those of you who are attending DocTalks for the first time, welcome. I know you'll be back, without a doubt. And for our regular attendees, welcome back. We're thrilled that you continue to join us and support these wonderful lectures. And for many of you, in addition to attending this event, we know that you are generous donors. And there's so much of what we do in terms of our care, our teaching, and our research that is made possible through donor support. It takes what's great care to extraordinary care. So thank you for that. The 2024 DocTalks lecture series is sponsored by Chartwell Retirement Residence Program, and Adrian from Chartwell is here. Thank you for your support. Please join me in thanking them for their support. Chartwell is Canada's leading leader in seniors housing. Their focus is people and supporting health, happiness, and peace of mind for older adults, their families, and the communities across the country. Through their many diverse residences, they offer flexible care and support options to meet the needs of older adults. And so thank you again for your sponsorship. We're very grateful. As you arrived this evening, you would have seen a booth about our capital master plan, and this is a really exciting time for our organization. We're starting to look 10, 20, 30 years out in terms of what are we going to need from a physical perspective, from a clinical needs perspective, to meet the needs of our community. And so many of you know that is changing, and there are so many predictions around what is care going to look like, and what does that mean for our hospital, not just within our walls, but outside of our walls. So you have a postcard at your seat. Community input and your opinion and your insight is very valuable to this. We're designing the future of healthcare with you in mind, and it's for you. So please take the time to scan the QR code and give us your feedback. As I mentioned earlier tonight, we are very pleased to have Dr. Sydney Hutnik as our presenter. In addition to being the ophthalmologist in chief at the Ivey Eye Institute, Dr. Hutnik is also a professor and the chair in the Department of Ophthalmology at the Schulich School of Medicine and Dentistry at Western University. And she holds the inaugural Marcel and Louise Brunette Research Chair in Ophthalmology at Western, a chair that is, of course, actually donor funded. She served as medical director of the Ophthalmology Basic Science Laboratory at the Lawson Research Institute in the Center for Clinical Investigation and Therapeutics for 18 years, and chair of research in the Department of Ophthalmology for 15 years. And research is so core to our work and to our understanding and how we improve healthcare outcomes. Our researchers and our clinicians, they work side by side to accelerate discovery and bring innovative techniques and tools directly into patient care. So I can't emphasize how important research is, and I know some of my colleagues are here tonight, and how closely we work together, and how, again, it's one of those defining things at St. Joe's that sets us apart. Dr. Hutnik first earned her PhD at the National Research Council before heading to medical school, and completed her residence training in ophthalmology. Following her residence training, she completed subspecialty glaucoma training. Throughout her career, Dr. Hutnik has held a number of leadership roles with medical and research organizations locally, provincially, and nationally. Her major research interest is focused on the, forgive me, pathophysiology and management of glaucoma, and she has supervised and mentored in focused research activities more than 200 students at all levels of training, ranging from high school to graduate science and medicine. This is such a core piece of who we are, is training the next generation and making sure they have the skills and the expertise they need to keep on and build on the legacy of the work of our clinicians like Dr. Hutnik. Her work has been presented and published both nationally and internationally, and she has been recognized with over 95 awards. So it's my pleasure to introduce Dr. Hutnik to share The Silent Thief, How to Protect Your Eyes.
Well, good evening, everybody. Can you hear me? Okay, then I want to start by thanking Patricia. That was a very kind introduction. And I also want to start by saying what a pleasure and honor it has been to be invited to give one of the DocTalks. You'll see in a few minutes why I think it's particularly important in today's age. I also want to start by giving my thanks to Chartwell Retirement Residencies and the St. Joseph Foundation right at the beginning, because more and more we're going to see why it's so important. And I've known Michelle and her team for the longest time. You can tell she's dedicated to all of the patients in our community, but also very supportive of both research and teaching. So, Michelle, it's such an honor to be part of this, because I know so much of this is you. So, we're going to talk about the silent thief, and maybe add a hint a little bit what we're going to talk about. But we're going to talk about why this is the silent thief and what you can do about protecting your eyes. We're going to hopefully use some time now to understand why the most common cause of blindness in London, in the province, in Canada, and the world is completely painless. We're going to understand risk factors to see if you yourself have any of these risk factors or your family. We're going to talk about how we diagnose and manage. And we're going to talk about a little bit about the Lawson Research Institute and some of the newest treatments and innovations that we're doing right here at St. Joe's and the Lawson. These are all my disclosures. I'll be mentioning something that we have a patent on, but I don't think it's in too much of a conflict. Now, for those of you who know me, and I know some of you, you know I like to talk with you rather than at you. So I know you're a little bit of a bigger audience, but we're going to try to make this a little interactive. So, warming up. The reason why I think DocTalks are so important is because we are inundated nowadays with fake news. So many patients hear about things they should buy and might work and might do this, and I have patients spending hundreds of dollars on things that we don't know if they're safe or if they're going to be helpful. So DocTalks, that's why you're so important, and you're getting more important every time you give a talk, because nothing today will be fake. So we're going to do a little exercise here. One of these is the real Prime Minister, who won't be my Prime Minister much longer. And one of these is the fake. Put up your hands. How many of you think this is the fake? Okay, let's see if you were right. Do you see how real that is and how easy it is for you to be faked? Morgan Freeman, an actor. Okay. How many of you think this is the fake? The black and white is the fake. And the last thing to show you here, this was a news clip, BBC News, President Obama. It was his voice, his image, and his words, and it was completely fake. So do you see how easy it is for all of us to be vulnerable to fake? So let's get a little bit warmer now. Show of hands, how many of you routinely think about your eyes? And we'll say, oh my gosh. Hopefully this is not fake. Okay. How many of you thought about your eyes in the last week without checking that this is the DocTalk? Okay, you're a good crowd. Okay, now I'm going to ask for some people to shout out some answers. What are some normal things that happen to our eyes as we get older? Normal. Reading glasses. Okay, yes. What else? Cataracts. Yes. Anything else? Dry eye. That's 3 of the 4. What's the last one? Oh yeah, blepharitis. It's true. That should be number 5. Macular degeneration. But remember, I said normal. I said the normal things. Pretty well, although I would put blepharitis in there as well. So these are things that happen to all of us as we get older. I say to my patients, they're normal, but I know they're very troublesome. In fact, patients will come in complaining, but sometimes when we're on call, we come in with patients severely concerned about some of these things which are normal. And we'll talk a little bit about how some of these normal things can actually lead to serious conditions if they're ignored. So whenever I think about the eye, and I think to explain things to patients, I like to fashion an eyeball to, I would call it an old-fashioned camera. And I think everyone in this room, including me, is old enough. Do you remember when cameras had film? They weren't digital, and you had to take the film to get developed, and then half the pictures came back as horrible because you didn't know they were horrible? Okay. So think about an old, we'll call it a non-digital camera, not old-fashioned. So light comes in and it gets focused by 2 systems called the lens and the cornea. That front window that you poke when someone pokes your eye actually focuses 2/3 of your light. So if you've got a problem with your cornea, which can be caused by dry eye, it can cause you to have blurry vision. The light comes in and it focuses on a part of the retina, which has a part called the macula, which has a part, and you've heard macular degeneration, the fovea. So we think about the retina as almost like the film in the camera, this little very thin tissue that captures that light. And then what happens is all of that electrical signaling has to exit the eye by something called the optic nerve. It's the cable that transmits all of that to the vision center. And maybe some of you know this, maybe you don't. The vision center of the brain that processes that into a vision is at the very back of your head. It's called the occipital lobe. So that light has to go. So within your eyeballs, even if your eyeballs are completely normal and healthy, if you've got a problem anywhere in your brain along that long pathway due to a stroke or due to a head injury, you still might not be able to see. So many people don't know, but the vision center is right there at the back. So when we talk about these normal things that are annoying and sometimes concerning, this lady right here got it right. So presbyopia is the need for reading glasses. So these little cables here called zonular fibers, they actually, when we're younger, are able to change the shape of the lens in our eye like a focusing camera. But when we get older, they start not being so helpful and they get a little bit sluggish. So that's why we need glasses to help us look up close. So an insufficient tear film, so our tears that line our eyes are made up of sugar, proteins, oils, electrolytes, antibodies. And as we get older, that balance goes out of imbalance. So eventually we get what's called an insufficient tear film. First, it might be just annoying, gritty, scratchy, uncomfortable eyes, but it can actually progress to something called ocular surface disease, which again can be quite serious because it leads to inflammation. Here's the other big one. 60% of people over 60, 70% of people over 70, 80% over 80. What happens here is our eyeball is filled with a big bag of jelly. If you were to cut a human eyeball open, you'd see this jelly called the vitreous. When we're young, it's homogeneous, it's attached to the back of our eye. We look through it, we don't notice it. But as we get older, it starts undergoing liquefaction, it turns into a liquid, so we start seeing our own solid jelly floating in our liquid jelly. Most of these floaters, called the posterior vitreous detachment, in 90% of people are normal, but in 10% of people, when the jelly pulls, it'll pull a hole in your retina, and you can undergo a retinal detachment. So when you do get these floaters and flashes, you should go get your eyes checked to make sure there's no hole coming in your retina. The last thing, and someone mentioned it, this lens of our eye, it does undergo changes as we get older. It doesn't matter who you are. We're all going to get a cataract. The good thing about, is we can do something about that. So those are the normal things. Now let's get really warm. What is the most common cause of irreversible blindness in London, in Ontario, in Canada, and the world. What's the most common cause of irreversible blindness? Okay, and I heard the two things, they're true, but yes, it's actually glaucoma. We know so much more about macular degeneration because if you wake up one day and your central vision is suddenly fuzzy, you notice it. And we'll go into why you don't notice you have glaucoma, and that's why it's the silent thief. So what we're going to hopefully do today is decide how many of us are at risk, our families as well as ourselves. Can glaucoma be cured? Can it be prevented? What can we do about it, and how? When I gave talks 10 years ago, I used to say, not to scare people, but the glaucoma tsunami is coming. We knew it was coming. Glaucoma tsunami is coming, but you know, not to scare you all, but the tsunami has arrived. And I'm going to tell you why it's no surprise. These data were put together by two colleagues of mine, Doctors Berman and Hodge, 20 years ago at the University of Ottawa. And what they did is they looked at the structure of the Canadian population by age group. So 20 years ago, the green line was the number of Canadians who were alive in the various age groups. They predicted by doing prediction science, 20 years later, which look at this, we're actually here now. Who would have thought that we'd be here so fast? There's been a shift over to the red line. So the good news about this is it means that the investment in heart and stroke research, cancer research, it's working. Canadians are living longer in their 70s and 80s. So that's all good news for us in this room. We have a better chance of being alive now when we're older than we were 20 years ago. But what they predicted, because the amount of investment in eye research is relatively less compared to cancer, heart and stroke, the things that kill you, the prediction was that you actually had a double chance of being visually impaired if you were lucky enough to live in your 70s and 80s and 90s. 70% of Canadians who now have vision loss are over the age of 70. So, this is part of what we're seeing. We've got a problem out there, the tsunami's here, but people, you know, and I think Patricia said it, the eyeballs are really one part of those body that you really don't think about until something goes wrong. Like we take our eyeballs very much for granted. So this is a wonderful study, and the reason why it's wonderful, look who funds it, the Bill and Melinda Gates Foundation. It's one of the best studies in the world where you can look at any country and look at any disease and determine the most up-to-date prevalence. So this study in 2019 showed that about 750,000 Canadians have glaucoma. But you're going to see that that's an underestimate because more than 50% of people with glaucoma don't even know they have it. But this is the most accurate data we have. Some buddies of mine at the University of Toronto did a study, completely different methodology, and they found the same 2.5%, which was interesting because two different ways to do the study and they came up with the same number. But what they found, and there's been many studies which have shown this, more than half of Canadians who have glaucoma don't even know they have it. And there you go. That's really why we're starting to call it the silent thief. The Perfect Storm with George Clooney and Mark Wahlberg. How many of you saw the movie? How many of you were hoping that George would make it? I was hoping he would make it. It's a movie, for God's sakes. But let me show you why I bring this up. So here was a crew of guys on a boat, and they were going about their everyday business. They were doing what they do every day. They had heard about these two powerful storms, which were risky, but that's not going to affect me. That's going to affect some other boats, not us. We need to do what we always do in a day and get our fish back in and get paid for that. So they ignored the risks. They knew the risks were there, but they ignored them. And by the time George Clooney found that, he goes, wow, maybe I'm in trouble here. He tried to turn his boat around, but if you remember that scene there, he didn't make it. And I hate to say it, that's what glaucoma is all about. So I'm going to show you something here, and I'm not one to blame the pandemic on anything. I'm one of those people who says we can't blame the pandemic on everything, for gosh sakes. But in this case, I'm going to show you what the impact of the pandemic has been on glaucoma. This is other reliable data coming from the Canadian Council of the Blind, Fighting Blindness Canada. And they did a study, and they did it in 3 stages. And the first stage was in 2019, estimated that 8 million Canadians, so 1 in 5, So if there's 200 people in this room, right, it's about 40 people that they predicted are living with an eye disease that can put them at risk for losing their vision. So again, there's that number of 728,000 known Canadians. The thing that really troubles me here is if you look at what we can do even today with our known treatments, with what we know and known treatments, we're still going to have about 1.2 million people with uncorrected vision loss. If we look ahead, and this is really not that far away, the 8 million is going to go up to 14 million, and the 1 million is going to go up to 2 million. So the take-home messages here are, number one, everybody should get their eyes regularly checked, especially by the age of 40 every 2 years. An eye care professional, the optometrist, they know how to do this, they're trained to do this. But the second message is, and I saw Lisa Porter in the crowd, there really is an increased need for research because what we're doing now is just not working good enough. So the need for research and innovation. So they looked ahead, that was 2019, and what happened by the time the pandemic hit? You will see that during that period of time, the hospitals were closed. So there were 45% fewer glaucoma surgeries, and look at this staggering number. 184,000 prescriptions for glaucoma medications were unfilled. That means either the patients who needed them weren't getting them, or the patients who were on their eye drops stopped taking them. So almost 2,000 individuals delayed in diagnosis, 7,600 patients did not. So we're seeing this still today. I just recently hired 2 new glaucoma surgeons at the Ivey. We're now having patients presenting at a much more advanced stage of the disease who need rapid access to care at an advanced stage, which is surgical. And this is probably the result of the pandemic. You can't just forget about glaucoma. Just like George on his boat, he should have paid more attention. So the question now is, what is glaucoma? So if you were to look in at eyeball, if you remember, and this is what we look in when we examine our patients, this is the optic nerve that we saw that connects the eyeball to the brain, but we're looking at it face on. So we're looking at that optic nerve inside the eye, and it's plummeting out of the back of the eye. So this is called the disc. The peachy tissue is the neural tissue. The yellow tissue is called the cup. The thicker vessels are the veins. The thinner vessels are the arteries. This is your retina, and in fact, your macula would be right over here. It's right beside your optic nerve. I always say that one of the exciting reasons I went into ophthalmology, it's the only part of your body where you can see naked blood vessels and naked nerve tissue. So we can tell a lot about your health by looking in your eyes if you have any problems that affect your blood vessels and your nerve tissue. So what makes glaucoma, first of all, very challenging is there's not one glaucoma. It's actually a group or a spectrum of diseases, and what they all have in common is they are an optic nerve disease. They're a nerve disease. Glaucoma is not a pressure disease. Most people come in thinking, medical students come in saying it's a pressure disease. But glaucoma can occur at any pressure in your eye. So we're going to go into why this is so confusing and why people think it's a pressure disease. Now the thing about glaucoma today, nobody knows how to cure glaucoma. Nobody even really knows what causes glaucoma. And the only treatment we have nowadays that can even delay the progression is by lowering the pressure. It's a surrogate treatment. We don't have any treatments that directly bring back the nerve tissue. So if there's one pearl that you can take home from tonight is you can tell everybody that you know, oh no, glaucoma is not a pressure disease. It's a disease of your nerve. Normal pressure in the eye ranges between these numbers of 10 and 21.5. And I have some patients with pressures of 30 who never get glaucoma, and I have some patients of 10 who go blind from glaucoma. So it's not a pressure disease. That's why more research needs to be done to figure out why some optic nerves are so sensitive to lower pressures. So here's the big one, risk factors, people in the crowd. So what puts you at risk? Because glaucoma is not a yes or no or on and off thing. It's sort of, you have a number of risk factors, and if you have a number of them, it tips over into you being told you have a disease. It's not black and white. So there's some things that we get on what we call history. We ask the patient questions, but there's some things that you get on an exam. And this is why you need to have your eyes checked, because you can't examine your own eyes in this way. So you can start checking off. Maybe you can check off if you have any of these risk factors. As we all said, Well, we can't do anything about this, can we? No. But certainly as we get older, our risk increases. Now, the thing about family history, just because mom or dad or grandma had glaucoma doesn't mean you're going to get glaucoma. It just means you have an increased risk. So if you're at a big family reunion and you haven't seen your Uncle Jack and your Aunt Bertha for years, you hate to do, when you're eating your piece of cake, but just, if you can somehow say, are any of you on any eye drops? Just see if there's people in your family that have glaucoma, because it increases the risk. Certain races get certain types of glaucoma, and it's not simple, but there is a race propensity. If you have heart disease, if you have diabetes, and if you're nearsighted, if your eye is made a little bit bigger than average and you're nearsighted, which means you need glasses for seeing far. If you have what are called vasospastic diseases, a rheumatological type of thing, if you suffer from migraines or something called Raynaud's phenomenon, if you've been bonked in the head, if you've had previous surgery around your eye. And here's the big thing. If you take certain medications in your body for other things, and these things can be taken for inflammation, especially steroids, all of these things can put you at risk. So those are things that you kind of know just by your history, but things that you can't possibly know unless you go to your eye doctor is what is your pressure, but it's not just the amount. Some people have pressures that really fluctuate. Your pressure could be 10 in the morning, 15 at night, and 22 before you go to bed. That fluctuation, and we're going to see about some exciting research we're doing right here at the Ivey. We're going to develop an home care, eye care tonometry program where you can measure your pressure at home. Cup to disc ratio, well, we look at that nerve, and if it looks funny, there's many things that we can do to call it funny. How many of you have had this test where they put your head in a machine and you beep, and you hate the test, don't you? Every single glaucoma meeting I go to with a bunch of glaucoma doctors from around the world, we talk about how much patients in South America, North America, China hate it, but it's still the test. If we see some broken blood vessels around when we look in your eye, if we see you've lost some tissue, if we see the blood vessels looking funny, and that front window we talked about, your cornea, if it's thinner than average, you can be at risk for glaucoma. So you can see you have to put all of this kind of together to make that decision of whether or not that patient has glaucoma. So why do we call it the silent thief? It's the most common type, or the most common reason for irreversible vision loss, and the most common type has no pain. The reason why it differs from macular degeneration, you can see, it starts robbing your side vision first. So people start getting what are called a beautiful scene out in the country, little clouds of glaucoma. These are called scotoma. And the clouds get bigger, and eventually you end up with tunnel vision. So you might be able to see straight ahead, but you can't see even a little bit to the right or left. So whether you're looking at scenery or looking at your grandchildren, what happens, it just comes and it relentlessly comes and takes away that vision. So we don't think of it as like macular degeneration because maybe it's not so dramatic, but it ends up being very dramatic. So this is called the continuum of glaucoma, and this could be you. This could be you at one end where you just have some risk factors, and this could be you, maybe where in your lifetime you lose some vision. And here's the other thing about glaucoma. This fellow Quigley, wonderful American, when he was younger, he looked at cadaveric eyes when patients were passed away. He looked at the anatomy of the optic nerve. And here's the thing. He found that almost 50% of that nerve would have to be damaged before you would clinically even notice a difference. He's still at it. Quigley is still at it. He goes to all the meetings, the big meetings in the US. He now knows through some of our modern day technology, and again, Michelle Campbell and her foundation helped the Ivey buy some of this equipment, which is so important. This is the scary thing. Up to 75% of the nerve is damaged or lost before we even get a change on the visual field. So that means 75% of the disease has gone on, and it's even there before we were able to detect it. So I'm going to show you an example. This is the patient, 68-year-old man, macho kind of guy, never been sick. The fact that he never goes to the doctor, I mean, maybe we don't know if he has these diseases, but he doesn't think he has any of this. He only takes Tylenol. And at the age of 68, he thought he would go to the eye doctor to get some reading glasses. He wasn't even wearing reading glasses yet. This is a real patient. That's not him, though. It's a real patient. I couldn't show it the real guy. So here are, you guys, again, you're now very, you know what an optic nerve head looks like. This is his right eye. This is his left eye. This is the optic nerve. The nerve tissue is pink. The cup is yellow. Here's the vein. Here's the artery. How many of you can see the difference between the right and left eye? How many can you see that? Can you say they're different? So here you can see the cup is larger, which means the nerve tissue is less. And if you look real closely, look how thick his nerve tissue is in this eye on what we call the superior upper portion, and look how it's thinned out. So the optometrist said, I think he might have a problem with his left eye. Here's that annoying test that you do, the visual field test. I show these to all my patients, and I say a point with a dot means there's no difference between you and normal, the age-matched normals. But this is his right eye. When we look at his left eye, he has what's called a scotoma. He basically has lost vision in the lower part of his left eye, and it's looking very suspicious of glaucoma. Now remember, you need 75% of your nerve dead before you even see that. So now we have something at the Ivey called the octocoherence tomography, where we can actually measure that nerve tissue in your eye at a micron level. Let's jump over to his left eye. These areas in pink are all the nerve tissue he's already lost. So he's what we call in the red because he's lost a significant amount. He not only has glaucoma, he probably has moderate glaucoma. And what's really worrisome, look at his right eye. He's lost tissue there as well. We just haven't picked it up yet on the visual field. So this man has glaucoma, and it's probably moderately advanced already. So that's again why it's the silent thief. Think about the challenge of trying to then tell a gentleman like that who's only taken Tylenol that he has a problem and he needs treatment. It's not easy. So what kind of treatments do we offer? Well, the first thing, maybe I'm going to say it now the fourth time today, it's very important to get your eyes checked with an eye care professional that has a slit lamp. On purpose, I'm showing this young man. That was one of my many students I've done research with. He's now finishing his residency in British Columbia. He's just graduating now as an ophthalmologist, Carter Lim. But he did a study where we actually washed patients out of glaucoma drops to see if there was a lingering effect. But you need one of those things that is called a slit lamp exam. You can't take a picture of your eye and send it into somebody and ask them if you have glaucoma. You need a slit lamp exam. So when we talk about treatment, and in general, we have what's called a traditional algorithm. We usually start with medicine, eye drops, and then if that doesn't work or you don't tolerate them, we go on to laser. And if that doesn't work, we go on to surgery. A bunch of us Canadians got together in 2016 and we published this paper because, believe it or not, the Canadian practice guidelines hadn't been updated, and they still haven't been updated since 2009. But what we did when we updated it, we changed the algorithm a little bit. So this is the traditional algorithm where you start with a bunch of eye drops. You can be on up to 5 bottles of eye drops before you go to surgery. But we realized with all of the innovations that were happening in glaucoma, you can now have other things, and you can do them earlier. You can have something called selective laser trabeculoplasty. And again, one of my residents who is now practicing at the Ivey, he did a leading study which showed that you can do laser as a primary therapy before you go on the eye drops. And it was just recently, 25 years later, that the rest of the world did a big study and said, oh, I think you guys in London were right. So we can now do selective laser trabeculoplasty as a primary therapy. But there's this other very exciting thing that is now here, and we're trying to get it here in London big time, minimally invasive glaucoma surgery. Surgery that's so safe, rather than waiting to the end, maybe we can start doing it closer to the beginning. In fact, just recently at a big congress that was held in Ireland, basically the glaucoma community agreed that it's time to change that paradigm. It may be that we start with one bottle, and then maybe we go to another bottle. Maybe we do minimally invasive surgery. Maybe we do that and go backwards. Maybe we go backwards here, and maybe, just maybe, we offer patients minimally invasive glaucoma surgery right from the beginning. So this is an exciting time to be doing glaucoma, because surgical glaucoma has never been so advanced, where we're almost looking at, let's jump in surgically before we do and treat medically. So it's an exciting time. Stay tuned, especially with minimally invasive. So now we go over to the part, and here's where Lawson Research Institute and the Foundation and St. Joe's helps out. If surgery is going to play such an important role earlier in the disease, we need to make sure it's successful. We need to do everything we can to make sure it's safe, reduce complication rates, faster recovery. So right now we've got a whole bunch of treatments that aren't bad. We're getting close to the target, we're treating, but you can see we're still a little bit uncertain. We're not really hitting the target with each patient every time. The goal would be to tighten up what we do and get more consistently closer to the target for each. And remember, each of you are different. What one patient may need may be completely different what another patient would need. But this is our goal at the Lawson Research Institute and St. Joe's. What we want to do for each and every patient, we want to get bang on with the right treatment for you. And we're hoping that we can do this with artificial intelligence helping us out. So, what we now have, and Patricia mentioned it, very fortunate, and I thank Michelle immensely. I thank the Marcel and Louise Burnett family. I thank Dr. John Gonder, because we do have a $5 million endowed research chair that is going to allow us to recruit and hopefully start a whole program where we use artificial intelligence, use precision medicine, and start matching the right treatment directly with the right patient. So that's what our aspirations are. So that's that. I'm going to tell you just a little bit. I know it's warm in here, you're getting tired, but I want to show you some of the stuff we're doing at the Lawson Research Institute. We have one of the few translational research labs in the country in ophthalmology. It's unique. There's very few centers in Canada which have this. So what we do is, we do what's called benchtop to bedside research, and this is the exciting part that Patricia mentioned. Every time we do things, I get students involved. These students then go on to become vision science researchers or ophthalmologists or something amazing. So the research I'm going to show you here, I'm not going to get into it too heavy, but I'm going to show you that each and every one of these learners was involved. So when you think about surgery, whether it's in your eye or your leg or your arm or your abdomen, pretty much everything has to do with a single word as to whether that surgery is going to be successful or not. And that single word is fibrosis. It's a fancy word for scarring. How much you heal and how you heal after, I think I saw a dentist that I know said hello to me today. Even in your mouth, wherever, when someone cuts you and then there's a healing response, it's how your body reacts to healing which will determine the outcome. In the eye, when we do surgery, if we have too little fibrosis, our surgery will leak because there's a hole, it's going to get infected. And believe it or not, your eye doesn't like high eye pressure, but it also doesn't like low pressure. But if we get too much fibrosis, the whole thing's going to fail. And if I'm telling you now we're going to be doing all this surgery, you'd be very disappointed if your surgery failed because it was all scarring down. So this is probably the most scientific slide I have today, but think about it. So here we have an eyeball. You've seen this. You've got fluid inside the eyeball, and it's just too high for that patient. What we do with all our surgeries is we make an opening and we bypass so that fluid now can go into a space which is a little bit on the outside of your eye called the bleb. But it's underneath tissue, so it's not leaking all over the place. When we're taking that fluid that's normally inside and we put it in this space, that space is saying, oh my goodness, I've never seen this fluid before. Because in that fluid are things that actually promote inflammation and scarring, because when you have a glaucomatous eye, these factors are in your eye. So this operation, believe it or not, we still do it. We still do it here at the Ivey. It's called the trabeculectomy. Here we're cutting that surface tissue called the conjunctiva. So it's the gooey tissue you can touch on the side of your eye right now. We go down to the white of your eye and we make a partial thickness flap. And that what's about to happen right here is called a Kelly punch. We're going to actually put a little hole right in that eye. It's called a sclerostomy. We're going to now make an eye, we're intentionally going to make a hole so the fluid can come out of your eye. We're going to sew this back a little bit because we don't want it to be like Niagara Falls. And then we're going to now take this conjunctiva and seal it shut so that this fluid is now being trapped into what's called a blister. So we on purpose make these things. Some of you might even have one of these. It's called a blister or a bleb. Now, when this operation was first about, the failure rate was almost 75%. In 1983, a drug that is used for cancer called mitomycin C was introduced, And mitomycin C is a cancer drug, it kills. Maybe Lisa Porter's ears are perking up here. This is what we call an indiscriminate killer. It would kill blood vessels, scar tissue, anything. And we basically use this to help increase our success rates. But unfortunately, even to this day, this is the only wound modulator we have. There's been no new innovation. And we don't even know how much to use, how many minutes to use, and how to apply it. So even today, our 5-year surgical failure rates are as high as 50%. So, at the Lawson Research Institute in St. Joe's, we said we need to do something better for our patients. So this very bright young student came to me and he said, Dr. Hutnik, I'd like to do a PhD with you. I'd like you to supervise my PhD. And I said, okay, what should we do? So what we did is we literally sat down and he picked my brains over what's the biggest gap in care. And I said, we need a better way to modulate our surgery. So what we did is we went into the Ontario database and we looked at 11,000 patients who had had glaucoma surgery. And we looked at, well, what were they doing that was leading to success and what were they doing leading to failure? So we found that patients who were on a certain postoperative antibiotic were more likely to fail, and patients who are on a postoperative anti-inflammatory were likely to do better. So we got a hint. So this is called benchtop to bedside. So we went out and said, this is a practical question. How can we go to our translational research lab at the Lawson and try to answer this? We then found that there was one non-steroidal anti-inflammatory, one you're all familiar with, called aspirin. But there's something very unique of aspirin. We didn't use aspirin the way that you think about using aspirin. We used one of its side effects or off-target effects to come up with our invention. And then we also used that specific antibiotic. And really what we were thinking here, we already know these drugs are safe in humans, but we're going to repurpose them in a completely different way to see if we can come up with something that can help with our surgery. So when you think about the invention we had, I can tell you someone had invented a pencil before, someone had invented an eraser, but the guy that invented putting the eraser on the pencil, he made a lot more money than the first two guys. So our invention was simple. Aspirin was out there, this antibiotic was out there. We decided to put them together and actually use them in a completely different way. And we actually came up with something not to just suppress inflammation, because when you cut into an eye, do surgery, you stir up inflammation, but we wanted to actually resolve, turn the inflammation off. And in doing so, we found that that would actually allow us to control the scarring. So long and the short, our patients on the operating table, we can take a little snippet of tissue at the time that they don't need anymore. It's called the Tenon's capsule. And we actually grew, these are primary cultures of fibroblasts from our patients' eyes with glaucoma. We grow them up in the lab. And we did first simple experiment where we compared aspirin with the chemotherapeutic drug. You don't have to know anything more other than the fact that we have these little nice in vitro assays where we can measure the amount of scarring by how much this tissue is contracted. All you got to know down here is that when you're down here, you're getting a whole bunch of contraction and scarring. But as you go up this way, you're actually reducing that. And we found there was no difference between the gold standard and aspirin. Aspirin could do what that chemotherapeutic drug was doing. We then did, and this is the first time I've ever seen anything so successful here, we then put the aspirin together with the antibiotic, and we were completely able to reverse the scarring. We almost had 100% where we could turn the scarring off. And that was our invention. Well, thank you. But you can see, then we did this with this nice, simple little assay. Now, so we actually went out to talk to venture capitalists because we were thinking we were really onto something here. And what they said is, well, you know, you need a little bit, even though you have these in vitro assays, you need some basically in vivo evidence. So this is one of my students now. She's a PGY2 postgraduate year resident in ophthalmology, Dr. Vinukurtseva. This was her work where we were able to show that the aspirin was just as good as mitomycin C. It was less toxic, and we had a mechanism to explain how it worked. So now what we're doing, this is another one, this is Richard Zhang. He's a PGY1 in ophthalmology. This was a lot of the work he was leading with a fourth-year thesis student named Samantha Gu. We're now doing these rat experiments. I never thought I would touch a rat, let alone his eye. On February 22nd, the weekend, I'll be hanging out with my students in the lab doing surgery on the rat eyes. We're now testing these, and we're actually at the stage where we're getting that in vivo data that the venture capitalists wanted to see, because it's going to move us closer to maybe being able to try this and do some preclinical work on humans. So this brings us full circle. Why do we talk about fake news, and why do we go to DocTalks to learn about all these things? Just want to show you this last piece of science that was done, research that was done, that actually looked at social media use in patients. And you can see the danger is that a lot of the stuff you get by social media tends to be promotional. So people are trying to sell you stuff that might not be helpful. So that's why, again, a little pitch for why DocTalks is just so important. So I think what we've done tonight, and we're winding down, is I think we've done something together called glaucoma literacy. I'm hoping after tonight that you all know that the leading cause of irreversible blindness in London, in Ontario, in Canada, in the world is glaucoma. It's the silent thief because 50% of people who have it don't know they have it. You already have lowered your risk by being here today, just being aware, and it's not fake news, it's good news. You know that you should be getting your eyes checked regularly with your optometrist. And also, don't fall privy to any of these fake things that some kind of fancy thing is going to cure you. The only way we know today to reduce your risk is by lowering your pressure in your eye. But I think we've gone farther. I think we've actually accomplished glaucoma literacy 2.0 tonight, because you all know that we can treat glaucoma with medicine, laser, and surgery. We know that we've got these exciting minimally invasive glaucoma surgeries that we are fighting so hard to make sure that the whole menu is here for you. We know that and I think one of the pillars of the Lawson Research Institute is surgical innovation. I see Lisa Porter, the Vice President, nodding her head. And one thing we're really excited about is setting up this program in artificial medicine and artificial intelligence and precision medicine. So before I go, I want to introduce one of my two, you know, you're kind of proud when you're the chair chief to bring on some talent. That's your job. Your job is to bring in great people who are better than you so that they can continue to offer good care. This is Dr. Sharon, and already she's just arrived. She's got research projects going on virtual reality, visual fields. You can do them at home. We're talking about doing this home care tonometry program where you can measure your pressures at home. And she's also looking at the effect of medications on implantable devices. This is Danilo Paulo, and he's already started this really interesting study looking at that laser we talked about and how it may affect the internal structures of your eye. So they're just great people, really busy. I'm excited that they're here. Last thing is, World Glaucoma Week is coming up soon. There's a website there. Lots of great things from around the world, free of charge for you to tune into and again, learn more about glaucoma. And with that, I thank you for your attention.
Good evening, everyone. I'm Michelle Campbell, President and CEO of St. Joseph's Healthcare Foundation, and I have the unenviable job of following Dr. Hutnik tonight. And I want to thank her for her presentation. And as you can imagine, we are immensely proud of Dr. Hutnik and the great work she does here at St. Joseph's. I know we have at least one patient. I'm willing to bet we have more of Dr. Hutnik's patients in the audience. And I can tell you, we know she is a beloved and compassionate physician because we get letters all the time in the foundation from many of her patients who are so grateful for the compassionate care that she provides. And as you've learned tonight, she's also a brilliant researcher, and she brings that scientific thinking and sense of curiosity and discovery into her daily practice. And we're very grateful for that as well, and the extent to which she inspires so many students to come and work with her. And we know she's got a real loyalty among that. Don't they look so young, all of them? I'm looking going, did they graduate high school? Like, how old are they? And speaking of age, Patricia Hoffer, my colleague, told you her Ivey story. I have a quick Ivey story, but it really underscores the point of why research in our clinical environment is so important. I used to be a candy striper here at St. Joe's back in 1977. Who remembers candy stripers? Ah, thank you. You know, I say that to my young staff and they go, what's a candy striper? I was a candy striper here at St. Joe's Hospital in 1977. I worked on the 5th floor, which was then belovedly known as 5EENT, 5th floor, ears, eyes, nose, and throat. And the vast majority of the patients cared for on that unit were post-surgical cataract patients. And in 1977, cataract patients had their surgery, had a 3 to up to 5 day hospital stay, had to lay flat on their back with their head between 2 bean bags. We were really high tech then, to keep their head from moving, and they were not allowed to get out of bed for 3 to 5 days. And so as a candy striper, volunteer nursing care was all around making sure that those patients got through that experience. Who's had cataract surgery recently? Yeah. You walk in under your own steam, you're there 20 minutes, and you walk out under your own steam. That is a very small but powerful example of what research does to advance clinical care on the front line. And that is all about the work of our Lawson Research Institute, working with our clinical teams here at St. Joseph's, and we're so proud of them. And you caught just a little taste tonight of some of the work and the advancements that result from that thinking and from that work. So I want to thank Dr. Hutnik and her great team at Ivey for the work they do. And something you may not know as Londoners is the Ivey Institute at St. Joseph's is the largest specialty eye center of its kind in the province, right here in London. All that specialty and all that critical mass is right here. I want to thank many of our donors as well who support the work of Ivey, who come to DocTalks. I know many, I see a lot of familiar faces in the audience tonight. Thank you so much for supporting that care. There's so much more we can do for Dr. Hutnik and her large team to advance clinical care on the front line of the type that we've heard about. I want to hear about MIGS later. I wrote that one down. That seems really interesting to me. I want to thank our great sponsor, Chartwell Retirement Residences, and I know Adrian's here tonight. Adrian, where are you? Oh, there she is. Hi, Adrian. Adrian, thank you so much to Chartwell for your support of this program. It enables us to film what we're doing, and you'll be able to pick up this presentation and be able to see it again online. We'll send a notice out once that is ready and that you can access that. And we have finalized our next lineup of DocTalks, and I think there's a slide that's going to come up to show you some of those dates. We've got a number of different topics there. Mobility from our Gray Center and Gray Research Chair, Dr. Shabrin. The moments of healing, trauma, and loneliness in healing, something we're very concerned about, that maps to our mission of body, mind, and spirit at St. Joseph's. Metabolic care, and osteoarthritis. So a number of continuing great lineup of speakers for our DocTalks presentation. So we'll have a link for registration to those upcoming DocTalks on our website in the next day or so. And I would be remiss if I didn't also mention that also coming up is the Foundation's Breakfast of Champions, our very large annual mental health breakfast coming up on May the 8th. Watch your inboxes for the exciting news of this year's speaker. We'll be going public with that closer to the end of February. So ladies and gentlemen, thank you again for joining us. Another thank you to Dr. Hutnik. Can you stay in case people want to engage with you directly? So you don't need to rush off, but if you do, we understand. And if you'd like to stay and visit with Dr. Hutnik or any member of our team, please do. Thank you so much for all your support of our work at St. Joseph's. Have a great night.